before I.
Good morning, everyone. We're just going to give everybody a moment or two to log on, and we'll begin shortly.
Welcome, welcome.
Okay, good morning, everyone. Thank you so much for joining us for Virtual Insights on Kidney Transplant. Our topic today is managing medications post-kidney transplant, tip for adherence. Our speakers are Judith Hambleton, Chief Transplant Coordinator, Eliza Bensley, Transplant Educator, and Giovanna Codespoto, Kidney Transplant Clinical Pharmacist. We encourage you to submit your questions in the Q&A section. Today's session will be recorded and sent to all those who registered. It is now my pleasure to turn things over to Judith, Eliza, and Giovanna.
Thank you. I'm gonna just take 1 second before Giovanna starts to share my screen. And I'm going to just take a moment to highlight my dear colleague, Judith Hamilton, who's going to probably yell at me after this, but today and tomorrow are Judith's last webinar series, and Judith is retiring, and we are so happy for her. And I just want to share this little video, and I know she's going to yell at me, but we're really, 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 really going to miss her. And she has dedicated 27 years to NYP in our program. So bear with me and humor me while I play this video. Judith, thank you for letting me do that. Everyone, please send Judith a little welcome and thank you, and we can get started. Giovanna, I'm turning the mic over to you.
Great, thank you, Eliza. And congratulations, Judith. Okay, so today I'm going to be discussing with you the management of medications post-kidney transplant and some tips for adherence. So we'll first begin by discussing the importance of anti-rejection meds post-transplant. So our immune system is designed to protect our body from foreign material. So in the context of infection, like bacteria, viruses, and fungus, your immune system protects you against cancerous cells, and it also recognizes a transplanted organ as foreign material as well. So by protecting your body from this foreign material, it can in turn potentially reject your transplanted organ if left without any like checkpoints. And that would be your transplant medications or your immunosuppressants. They're used to intentionally weaken your immune system to prevent your body from attacking the transplanted organ, which in the context of this presentation would be the kidney transplant. I like to think of your medications post-transplant in 3 different buckets. They're your anti-rejection medicines, which we discussed earlier, and then your anti-infection medications. Those medicines are being used to protect you against infections, being that your immune system will be lower than it is when you're not taking that medication, so pre-transplant. And then the third bucket is every other medication that you take that keeps you healthy. So the first part of that pizza pie are the anti-rejection medicines. You'll hear me talk a lot about these medications over the course of this presentation. They're meant to prevent rejection and damage to the organ. Patients are generally on 2 or 3 different anti-rejection medicines after the surgery. Some of them are given through the IV immediately after the surgery, and you'll start on some of the maintenance pills, and the pills are what you'll go home on after you're discharged from the hospital. The risk of rejection decreases as time goes on past the transplant date. So over time, the doses of your anti-rejection medications are decreased. However, you will always need to be on some form of anti-rejection medicine for the rest of your life. So even 10 years after the transplant, you feel great. The kidney numbers are wonderful and you're making a ton of urine. If you stop taking your anti-rejection medicines, your body's immune system will recognize that that foreign kidney is there. It doesn't get used to it over time. The next part of that pizza pie are the anti-infection medicines. So the anti-rejection meds protect the kidney, but the anti-infection medicines are protecting you as a whole to prevent you from getting some infections that you're more susceptible to because your immune system is lower. All patients start with 3 different anti-infection medicines, and they cover the various viral, fungal, and bacterial infections. Over time, like we discussed, the anti-rejection medicines dosing decreases. So your risk of infection becomes less as your immune system becomes a bit more robust. So because of that, your risk for infections also decreases over time. So at our program, all of your anti-infection medications are generally stopped by 1 year, potentially at 6 months. So the medication list will shrink over time as you progress further from the surgery. And then the third piece of that pie are all of the other medications that keep you healthy. So you might be started on medications to measure your blood pressure, your blood sugar, and perhaps you may be on medications that a kidney transplant doesn't fix. So there are medicines that you would continue after the surgery to keep the rest of you healthy. That being said, some medicines that you were taking prior to transplant may not be restarted after the surgery. And you'd be informed of which medications those were at the time of your discharge. We'll get now into more general medication information and some tips that you can use when you're managing your medicines. So as I will continue to stress over the course of this presentation, taking your medications after transplant are very important, and it's required for you to keep that kidney nice and healthy in your body. It's preventing rejection and also preventing infection in the cases of some of the medicines. So adherence, meaning taking your medications every day at the same time, ideally with no missed doses, is very important. Patient education is something that's stressed pre-transplant, which you guys are already attending this webinar, which is wonderful, getting ahead of it. And then post-transplant, you'll get more teaching by one of the transplant pharmacists and also by all of the post-transplant staff. There are some things that will set you up for success when you're learning about your medications. It's a lot of information, but ideally you should know 3 things about all of your medicines: the name of the medication itself, the brand name and the generic name, the purpose of the medication, so which one of those buckets does it fall into, and then how exactly you should take that medication, including the correct dose and the timing. So how many milligrams is the pill? How many tablets of that specific medication are you supposed to take? And then what is exactly is the timing? Is it a once-a-day medicine, twice-a-day medication? After transplant, your medication regimen will change drastically. So it's not expected that you'll be an expert at all of this immediately after the surgery. So you will be provided with a medication list, which I'll review with you what that will generally look like in some later slides. That list should be a piece of paper that comes with you to every clinic visit, to all of your doctor's appointments, even for other doctor's appointments that are not kidney transplant clinics. So you go to your cardiologist or whatever it is, you bring your medication list so you can show them, these are all of my medicines. Like I stressed before, compliance and adherence is very important. So you should be taking your medications exactly as prescribed, never intentionally skipping doses or missing doses if possible. To make things easy for you guys, we tell you that you should be refilling your meds on time, ideally calling the pharmacy 1 week ahead of running out of refills. I think we've all experienced the stresses at the retail pharmacies where you may rely on the automatic refill, and for whatever reason that the pharmacy doesn't process it, or you have some sort of insurance issue where now your refill is getting delayed and you might possibly be completely out of medication, or they need to order you medicine, whatever it is, you might have a bit more grace with some of your medicines pre-transplant, but after transplant, we don't want you to go without medication. So worrying about getting those refill reminders and letting your pharmacy know that you're due for refills a week ahead of time allows for all of those issues to be taken care of before you run out of pills. And then, like I previously mentioned, you should always also carry around an accurate medication list with you. There's a fair amount of drug interactions post-transplant, specifically with the anti-rejection medicines. These medications can interact with other medications that are commonly used pre and post-transplant, and the interactions can be significant, and they could potentially cause you harm or cause harm to the organ if it's not addressed by the transplant team. So the golden rule after transplant is that you should never start a new medicine, whether that's an over-the-counter medication, an herbal supplement, a vitamin, or even a prescription medicine without calling the transplant team before you start it. So even if you go to a different physician or you go to the dentist, they want to start you on antibiotics, you should call before you start it, just so we can make sure there's no issues with those meds. And generally, we try to limit the herbal supplement and dietary supplement usage because they're not regulated by the FDA. But if you're considering, I want to take this herbal supplement or this vitamin, just have an open communication line with your provider. That way they can make sure it's something safe post-transplant. Over-the-counter pain medications are limited post-transplant as well. This might be something that you guys are already adhering to, because with end-stage kidney disease, most patients are told that they can't take NSAIDs or non-steroidal anti-inflammatory drugs. Some examples of those are Aleve, naproxen, Advil, ibuprofen, Motrin. All of those medications are not safe post-transplant. And that includes like regular strength aspirin that you're using for pain relief. If you're on a baby dose aspirin for heart protection or for vascular reasons, that's a different story, but you shouldn't be taking an aspirin because you have a headache. The only over-the-counter pain medication that's safe post-transplant is Tylenol or acetaminophen. Along with interactions with medications, there's also some interactions with foods, specifically fruits. So you might be familiar with the fact that grapefruit juice interacts with some medications. That also applies to the transplant medications, and there are a few other fruits that we ask that you avoid as well. So grapefruit, pomegranate, and starfruit, which is a more exotic fruit, have interactions with your main anti-rejection medicine, tacrolimus, which will go into the names of the medicines in the next few slides. That goes for eating the fruits, also drinking the juices. And then to be extra careful, we also tell you to avoid things that are flavored with fruit extracts, because it could have an effect on your anti-rejection medicine. So there are some examples on this slide here. Sunny D, grapefruit LaCroix, Fresca, all of those drinks have some sort of grapefruit extract in it. So those would be things that you would need to avoid post-transplant. But all other fruit, vegetable juice is fine. There's some examples on the slide here. As long as we're not having you limit your potassium, you can drink as much of this stuff as you would like. The role of the transplant pharmacist plays a pretty heavy hand in what will happen with your medication teaching post-transplant. So you'll meet with a transplant pharmacist, usually on the day of your discharge, and they'll review with you your medication regimen that you will be adhering to after you're discharged. We generally encourage you to have at least one support person or caregiver that will be with you at home when we do this education session, just because it's a lot of information. You will probably be in some pain, not feeling super great. You just had a pretty big surgery a few days before then. So it's always good to just have a second set of ears listening. Everything that you get will be written down. So you can always refer back to it. And then you'll also see the transplant pharmacist in clinic after your discharge, but it's always good to have that second set of ears. At that point of education is when you'll get the full review of all of your medications, and you'll get that medication list. Like we said, that's the most important thing that you bring with you to all the doctor's appointments. That list will be inclusive of all the medications that you take after transplant. So including the meds you were on prior to that we want you to continue. This list will have exactly how you take the medicine. So it will have those 3 bullet points that you should know about all your medicines, so that it'll have the drug name, the brand and generic. It will have the strength and the purpose of the medication, and then also exactly how you're going to take it. So the dose and the timing. Something that's very different than before transplant is that after the surgery, you're coming to clinic for your doctor's appointments frequently, getting blood work often. It's usually around 2 or 3 times per week for the first few weeks after the surgery. The dosing of your medication changes based on some of your blood work. So you should never rely on the instructions that are written on your pill bottles, because as you come to clinic, we tell you to take the medications differently. You'd get a new printed out medication list. So when you fill your pill box and when you're telling other providers, these are the medicines I take, you only follow directions on your medicine list, because your pill bottles might not be as accurate if something's changed since it was dispensed. This is an example of what a medication list looks like after surgery. So these are the 3 anti-rejection medicines that you might potentially be on after the surgery. You can see here that the names of the medicines are in bold. This is the generic name of the medicine, and it says underneath, commonly known as Myfortic. That's the brand name. The directions are underneath. So this says here, take 2 tablets by mouth every morning, 1 tablet every night. And then we use this grid here because it's going to match up with the pill box that you'll go home with that also has morning, afternoon, evening, bedtime slots. So you're able to just quickly fill in the pills, and it makes it a bit easier when you have all those pill bottles in front of you. And you could see here prednisone, same thing. This one's only in the morning time. And then the tacrolimus or Prograf, which is the brand name for this specific example, this patient was doing 6 capsules in the morning, 7 at night. These medication doses are tailored based on you and blood work, so this is just an example. When you're discharged from the hospital, along with that medication list that you'll get from the transplant pharmacist, you'll also get a 1-month supply of all of your medications, the new medicines that we have started. You'll get a blood pressure cuff, a thermometer, that 7-day pill box, and then potentially, depending on if you have diabetes or if your blood sugar is elevated, we may or may not send you home with a glucometer to check the blood sugar. We're going to get a little bit more in detail on the actual transplant medications now. You've heard me throw around some of the names at this point. So again, we're going to go back to our 3 buckets. So our anti-rejection medications are first. So these are the most important meds post-transplant. They're also called immunosuppressants or your immunosuppression. These meds are protecting the kidney from rejection and preventing damage to the organ. And again, these are medications that you will stay on for the rest of your life. So we saw that example medication list earlier. So generally, patients are on 2 or 3 different medications, so tacrolimus, mycophenolate or Cellcept, and prednisone. Tacrolimus or Prograf is the main anti-rejection medicine. This is the most important medication that you'll take post-transplant. It comes in different strengths. You can see there's a 0.5 milligram capsule, a 1 milligram, and a 5 milligram capsule. This medication dosing varies very widely based on patient-specific factors. We actually measure the amount of the drug in your blood. And then if it is in range or out of range, we tell you if you should continue to take the same amount of capsules or if you need to make some adjustments. It's a twice-a-day medication, so it's taken 12 hours apart. And generally, after the surgery, you'll be taking medicines at 9 a.m. and 9 p.m. So this would be a medicine that you take at that time point. It doesn't necessarily, taking medications with food is not 100% necessary. However, the important piece of that information is to make sure that you're consistent with food intake. So depending on if you eat if you, let's say, ate breakfast and then you took your pills at 9 a.m. or you took your pills on an empty stomach, it affects the amount of the actual medication itself that's being absorbed, which we can dose adjust if you're consistently eating breakfast and then you always take your pills after. So consistency is the important thing. You shouldn't flip-flop between, like, some days I eat breakfast, some days I don't. I generally advise patients that if you like to eat breakfast and it fits into your schedule, you should eat before you take your meds. It'll help you tolerate the amount of pills that you'll be taking, at least for that initial period after the surgery. We generally also want you to be consistent with the manufacturer. So ideally, you should be getting the same manufacturer of your medications from the pharmacy each month. Granted, sometimes stuff happens. There's back orders on certain manufacturers, or the pharmacy is not able to get a certain manufacturer in stock. If that's the case, if you pick up your meds from the pharmacy and they look different, we want you to call us, because we might have you come in for blood work a little bit sooner, just because the amount of the active medication that's in the capsules varies very slightly between different manufacturers, whether it's the brand name or the different generic manufacturers. So just always let us know if the manufacturer is different, because we don't want you flip-flopping each month to different manufacturers of the pills. Here's some examples of how the dosing is done post-transplant. So the white pills are the 1 milligram capsules, and this is just one specific manufacturer. Your manufacturer that you get from the pharmacy might look different, but all three of those dosing strengths will have different markings and different coloring on it. So the first example, there's 3 1 milligram capsules. That would be a 3 milligram dose. The next is a 2.5 milligram dose, because that yellow capsule is a 0.5 milligram. And then a 6 milligram dose would be one of the 5s, and then one of the 1 milligrams. You could also make 6 milligrams by taking 6 of the 1 milligram capsules, but ideally we'd like to limit the amount of pills that you have to take. Like I had alluded to earlier, this medication is dosed based on the level of the drug in your blood. So we purposefully have to draw your blood work in the morning at your clinic visits prior to you taking your morning dose of tacrolimus or Prograf. Generally, your clinic appointments are going to be at like 7:30. So it's too early for you to take your pills anyway. Meds are due at 9. So you would come in, you bring your pill box with you. You'd get your blood work drawn, you'd see the doctor, and then at 9 o'clock when meds are due, you can take all your pills. And then there's just a written example of how dose changes would work, which I explained earlier. For example, if you're above the range, so you have too much drug in your blood, you're too immunosuppressed, right? There's too much drug. So we would decrease the amount of medication that you're taking. So if you were taking 3 milligrams, maybe we'd go down to 2 milligrams. On the flip side of that coin, if you are below the range, you are not immunosuppressed enough, so you're at risk for rejection, so we would increase the dose. Here are some side effects that are listed on the slide here. I won't go through everything, but the most common side effects that I like patients to be aware of, one is a hand tremor and a headache. Usually the tremor is more so related to you having higher levels of the drug in your blood. So if you wake up one morning and you're very shaky, give the clinic a phone call. We might want to send you even somewhere locally to get labs, and then we can adjust the tacrolimus dose and the tremor should go away. Some patients experience a headache like an hour or so after they take their medicine. It should be a dull headache that goes away with the Tylenol, but if you have like a pounding headache that nothing is helping, or just like consistent headaches, let us know. Tacrolimus can increase the blood pressure, increase the blood sugar. It sometimes can give patients some trouble sleeping. These are all things that we'll ask you at clinic. We have you monitor your blood pressure at home, and then also we'll check it at clinic. And then depending on if you have diabetes or not, you might check your blood sugars at home. And if not, we would check it on your labs. Something that frequently gets questioned is the side effect of kidney damage. Most of us are getting kidney transplants, right? So we are getting this brand new functioning kidney, and then you're potentially taking a drug that can cause kidney damage. And this is kind of the Achilles heel of transplant. Tacrolimus is the best drug that we have for preventing rejection. But we do know that over time, it can decrease your clearance or your eGFR, but a pretty marginal amount. So over time, the course of 10 years, your clearance may decrease by 10 points. But in the context of your clearance being 60 and now it's 50, it doesn't really affect your life much. So we use tacrolimus knowing that over time it can cause some kidney damage, but it will protect your kidney from rejection more so than any of the other medications that are on the market for rejection or for anti-rejection medications at this point. Hopefully with advancements in transplant medicine, we can forego that Achilles heel of transplant of tacrolimus, but at this point, this is the standard of care for transplant around the world, really, for every organ. The next medication is CellCept or mycophenolate mofetil. This is a medication that also prevents rejection. There's two different strengths that it comes in. It comes in a 250 milligram capsule or a 500 milligram tablet. This medicine is not dose adjusted based on your blood work. So whatever dose you go home with will more than likely be the dose you stay on forever, unless you're having a side effect that adjustments need to be made. Similarly to the tacrolimus, it's taken twice a day, 12 hours apart. And generally it's recommended to take it with food because it can cause some nausea, heartburn. So again, especially if you're a breakfast person, I would advise eat your breakfast, take all your 9 a.m. meds either with breakfast or after breakfast. Side effects are similar to what I just mentioned, stomach upset being the most common one. Most frequently, patients can experience diarrhea. So this will all be information that you are relayed prior to your discharge. But if you have frequent episodes of diarrhea, you give the clinic a call. Basically, if you're ever feeling like, is this a side effect? I don't really know. I don't feel right. You call clinic and they'll discern whether or not it's something that's medication related or if it's something that, needs further investigation. Taking the medication with food does help to decrease this potential side effect of stomach upset. So again, it's probably a good thing to take your meds with food. CellCept can also cause low white blood cells, red blood cells, and platelet counts. That's nothing you would feel. It'd be something we see on your labs and then make dose adjustments if necessary. Birth defects is something that's relatively unique to mycophenolate. So females of childbearing age need to be using effective birth control while you're using mycophenolate. Generally, patients are not getting pregnant immediately after the surgery. It is possible to have a healthy pregnancy after you've had a kidney transplant, but you need to communicate with your gynecologist and obstetrician as well as your kidney transplant doctor because you would need to be switched off of mycophenolate 6 weeks before you start trying because the medicine needs time to wash out of your body. There are alternative medications that you would be put on for the course of your pregnancy. And then after that, you'd go back on the mycophenolate once you've delivered. If you do accidentally become pregnant after transplant, the transplant team should be notified immediately because they need to make that switch to a different medication. This does not apply for males who are hoping to have children. There's no interaction or risk to the baby or your female partner as if you are on CellCept. It's specifically for females that are taking the drug. There is potentially a risk that if somebody is helping fill your pill box, that the medication powder that's coating the tablets or whatever it is could be absorbed through the skin. So if you have a caregiver that's a woman of childbearing age, they should wear gloves when they're helping you with your pill boxing. And then the last anti-rejection med that we'll talk about is prednisone. So prednisone is a steroid. It's used for a lot of different indications. You may pull a muscle in your back or hurt your foot. Your doctor puts you on a steroid, or maybe you have some sort of upper respiratory infection and you get put on steroids. It's a common anti-inflammatory drug, and it's used immediately after transplant, given through the IV for all of our patients. And then some patients are discharged home on prednisone, depending on your risk for rejection. There are various tablet strengths, but if you do go home on prednisone, it would be a 5 mg tablet at discharge. And at the time of your discharge, you would be given instructions on how you're supposed to taper your prednisone. All of our patients generally go home on 20 mg of prednisone if that's part of your regimen. And over the course of the next few weeks, the dose tapers lower and lower, with the goal of you being on around 5 mg or less of prednisone a day. If you do go home on prednisone, it would be a maintenance medicine for you. So that would be your 3 anti-rejection medications. It is a once-a-day medicine, and it should be taken with food just because it can cause a bit of stomach upset if you take it by itself. Some of us may be familiar with some of the side effects of prednisone. Depending on what caused your end-stage kidney disease, you might have taken prednisone or steroids in the past. The most important ones that I like patients to be aware of are more so the long-term use of steroids, because we're not really using high doses of steroids for long periods of time. On discharge, like I said, you're on 20 mg with the goal of getting you down to 5, which is approximately the equivalent amount of cortisol that your body naturally produces every day. So you get down to pretty much a physiologic dose of cortisol, usually by the first month or 2 after the surgery. Prednisone can increase the blood sugar and blood pressure. Again, these are things that we monitor. Long-term use, it can cause decreases in calcium and vitamin D absorption and lead to bone loss. So you should get your yearly DEXA scans where they check your bone density, and then we'll also supplement those vitamins if needed. High doses, sometimes even patients that are a little bit more sensitive to it, at the 20 mg dose, they have some trouble sleeping or they feel a little bit more irritable. But that's why we purposefully make you take your once-a-day dose in the morning time. So hopefully by the nighttime when you're winding down, getting ready for bed, that effect should have washed out and you shouldn't have issues sleeping, hopefully, with taking it in the morning. Now we'll transition to our anti-infection medicines. So that's the second piece of that puzzle there. So the anti-infection meds are preventing you from getting potential infections because you're at higher risk, being that your immune system is weakened from the medications that we're giving you. So this gives you an example of a schedule for what you would potentially be getting after transplant. Like I had mentioned, you get coverage for viral, bacterial, and fungal infections. And you can see here there's varying timelines for when those medications come off of your list. So it generally ranges from around 3 months to potentially up to 1 year for some of the medicines, but by the 1 year mark, you should be off of all of those medicines. We'll talk about the antiviral medications first. So valganciclovir or Valsite is one of the antivirals that our patients take. It's preventing a certain type of viral infection that most of us have been exposed to in the past called CMV or cytomegalovirus. In a person with a normal immune system, you have no symptoms of this and it doesn't cause an infection. But being that your immune system will be weaker, you can potentially become symptomatic from this infection. So all of our patients, if you've been exposed in the past or your donor has, will get this medication, valganciclovir. It's a 450 mg tablet. It's taken once a day. And generally by the 3 to 6 month mark, you're done with the Valsite. Acyclovir or Zovirax is the other antiviral that we use. This medication is a 400 mg dose, and it's dosed twice a day. And this one stops after 3 months of use. Again, this is just for your general information, but your transplant nephrologist would let you know when it's time to stop these medicines. The side effects are relatively similar for these 2 medications. Stomach upset could potentially be a side effect. Specifically with the Valsite, we can see lower white blood cell counts, red blood cell, and platelet counts. Again, that's nothing you feel. It's results we see on your blood work and then make adjustments if we need to. And the hope is that by giving you these prevention medicines is that you don't get the infection because we're preventing it by giving you medicines. The next medication is Bactrim. This is an antibacterial or an antibiotic. Bactrim has a very long generic name. It's not even written on this slide for you. It's abbreviated here, sulfamethoxazole trimethoprim. Nobody will refer to it as that, except for the transplant pharmacist when you get your medication teaching. We all just call it Bactrim. So think B for Bactrim, B for bacteria. It's preventing certain types of bacterial infections. So it helps protect against urinary tract infections. And it's also helping protect against a certain type of pneumonia that patients with lower immune systems can potentially contract. The dose that we use is 1 single strength tablet. Again, it's a combination pill of 2 different antibiotics. So that's why the strength is 400/80, which is equivalent to a single strength tablet. And the dose is 1 single strength tablet every day. And it's generally stopped at 1 year. We have been looking at potentially stopping it a little bit sooner, which is better for you guys, less medication. So it might be 6 months by the time that you guys are transplanted. As far as side effects go, Bactrim does have sulfa in it. So patients that have sulfa allergies, we would not be using Bactrim in you guys. You could potentially, with any of the medicines, or with anything in general, you could develop an allergic reaction. So if you developed a rash or you were itchy after you took the medicine, that's not a super uncommon thing. Sulfa is not like a very rare allergy. So if that were to happen, we'd put you on an alternative medicine to protect you against those infections. Bactrim does make your skin sensitive to the sunlight. So you need to make sure you're wearing at least SPF 30 and covering up your exposed skin when possible. Taking a step back, being on anti-rejection medicine at baseline, because it lowers your immune system, and we talked about how your immune system protects you against cancer and abnormal cells, being on anti-rejection medicine puts you at higher risk for skin cancer. So even though the Bactrim increases your sensitivity to sunlight and you're on it for 6 to 12 months, even after you stop it, you always need to protect your skin because the anti-rejection medicines will be medications you'll need to take for the rest of your life. Bactrim can sometimes have some effect on the blood counts, so the white blood cell count, the red blood cell count, and the platelets. But again, that'd be something we see on your blood work and then make adjustments if needed. Clotrimazole or Mycelex is an antifungal medication. And this is a unique medicine because even though it looks like a pill here, it's actually a pretty big tablet and it's a lozenge. It's not a pill. So it's not something that you would be swallowing. It'd be something that you're letting dissolve on your tongue to prevent an infection called thrush. Some of us you may know someone that has had thrush in the past. It's not an uncommon thing for babies to get thrush. People that use certain inhalers can get thrush, and patients that have lower immune systems can also develop thrush. And it's an overgrowth of fungus on the tongue. It looks like a white fuzzy plaque. It can affect it might hurt when you swallow or your taste is affected. So everybody gets this infection, antifungal medicine to prevent you from developing that. The lozenge is taken twice a day. It's with your 9 a.m. and 9 p.m. medicine, but the medication itself has a local effect, meaning that, you let the lozenge dissolve on the tongue and then it prevents fungus from growing by coating the tongue. So after you use the lozenge, it's important that you don't eat or drink to allow the medicine to actually sit on the tongue for a period of time. And we tell you around 15 to 30 minutes. After the lozenge dissolves, you let it, have time to take effect. If you drink something right after you use the lozenge, the medications just get washed away, it goes in your stomach, and it doesn't do anything at that point. The Mycelex is the first anti-infection medicine that will come off your medication list. It's generally stopped by the 2 to 3 month mark post-transplant. Something that's different about the Mycelex and these other anti-infection medicines is that this medicine actually boosts up the level of your tacrolimus, which that's the main anti-rejection medicine. So we talked about that there's pretty significant drug interactions with tacrolimus. There's a drug interaction with clotrimazole and tacrolimus, but we use it intentionally because it boosts up your level. So that being said, taking the lozenge is just as important as taking your tacrolimus, because if you skip the lozenge and think like, oh, it's no big deal, the levels of your anti-rejection medicines will start to vary. So lozenge should be taken just as routinely as taking the anti-rejection medicines. It's a twice a day med, so it should just be after the 9 a.m. and 9 p.m. meds. You pop the lozenge in, and then after it's dissolved, you wait 30 minutes before you eat or drink anything. Once the lozenge is stopped, we carefully monitor your tacro level, because the level will start to drop and we'll need to make dose adjustments. Now, I know that was a lot of information, and especially right now where you're just kind of learning about stuff and you don't have much context pre-transplant, it can be a lot of info. All of this that was discussed will be discussed again post-transplant. So you guys are all getting ahead of the game, which is great. But here are some key points to remember and key takeaways out of this presentation. So it's important that you learn your medications. And you should always carry around an accurate medication list. It is normal that you're overwhelmed post-transplant with just the amount of changes that were made. There's a big adjustment in your normal medication routine. But just like you know your meds now with your, pre-transplant medicines, you'll get there with the post-transplant meds, but it takes time. So make sure you always have your accurate medicine list with you, and you'll get updated ones as things change at the clinic. Medicines should be taken exactly as prescribed. So exactly what's written on that medicine list, you follow that. If you ever have questions, you'll get the direct line to the clinic that you'll be able to speak with someone. And that being said, you should never be intentionally skipping doses. And ideally, life happens. We would want you to not forget to take your medicine, but we'll give you some tips and strategies as far as how do you manage, I missed my medicine, what should I do? That's information that will be given to you at the time of your discharge teaching prior to you leaving. All of our patients go home with that 7-day pill box, and the pill box is a great visual reminder for you to check the pill box itself. Did I take my meds today? So fill your pill box up once a week. And then if you're ever like, did I take my meds this morning or was that yesterday morning? I don't remember. Physically look at the pill box for Tuesday morning and you can check if the pills aren't there, you took them. If they are there, then you haven't taken them. So pill boxing is very important post-transplant. Most patients love the pill box and continue it even after they become experts on taking their meds. You should always talk to the transplant team prior to starting any new medicines. And then specifically for the over-the-counter pain medications, the only medicine that's safe after transplant is acetaminophen or Tylenol. You should not be taking anything else that's over-the-counter for pain. Advil, Motrin, Aleve, ibuprofen, regular strength aspirin. All those are good for the new kidney. So with that concludes my presentation here, but I would be happy to answer any questions that you guys have.
Oh, absolutely awesome. After 30 years in transplant, I still learned something from your presentation. Absolutely great. For those of you that would like to ask any questions, you can type them in the question and answer box. We can certainly give you a few minutes to come up with those. I find it easy. I think one of the questions that I get most from the patients, they can't quite understand, it's like, don't take my medicine. How many times do people come to their clinic appointment and have actually taken their medicine? We've got them so well trained now to always take your medicine that they tend to forget that.
Yeah, that definitely is not an uncommon confusion that patients have, but we try to make it as easy for you guys as possible. The meds are due at 9 a.m. You're going to be at clinic at 9 a.m. So you'll have your blood drawn before 9 o'clock, and then you can take your meds on time at 9. Like most people are trying to be very regimented, which is a great thing. But hopefully that timing also reinforces the fact that we need to draw your blood work before the morning dose of the meds. So bring the pill box with you. You'll also be instructed to bring the pill bottles with you because we'll help you fill the pill box if you have questions or you want assistance or you want to review things. But yeah, just bring everything with you because most people are commuting from, a little bit further away. You might leave the house at 6 a.m. for a 7 o'clock appointment. It's too early to take the pills. Just bring them with you. And then we'll let you know when it's time to take them.
Thank you. So we have a few questions coming in now from Miss G. Is there a time frame for a person's immune suppression to lessen?
So that's a great question. And we do have a protocol for how we decrease the goal tacro level or tacrolimus level that we have. Generally by the 1-ish year mark, you're on half the amount of tacrolimus that you were on before or like immediately after the surgery. The dose of the Cellcept or the mycophenolate won't necessarily change. And then the prednisone dosing will also be lessened. So generally by the 3-ish month mark, the strong anti-rejection medicines that you're getting through the IV immediately after the surgery have washed out of the body. You're on less anti-rejection medicine. Usually by the 3 to 6-ish month mark, patients they're going back to work, they're back on public transportation, that type of thing. But it's more so in that immediate 3-month period where you're at the highest risk of infection, which is why we give you all those anti-infection medicines at that time point.
Thank you. Next question. If I get tacro headaches, is there a time release version?
That is also a wonderful question. There is an extended release version of tacrolimus. It's called Invarsis. It's a once-a-day medicine, and it is time released, so you don't have that quick absorption. So generally, patients do have some improvement in their headaches with switching to that time release formulation. There are other medicines that replace tacrolimus too. So although this is the gold standard and ideal, all our patients will start out on it, it is a patient-specific regimen. So if you're having side effects or you're having terrible headaches with the immediate release formulation, we try the extended release formulation. There are other options too. But yes, we do sometimes employ the time release version.
Anyone else got questions?
No, but this was fabulous.
Yeah, it really was.
Really fabulous. I think the next couple slides, Giovanna, you can just proceed through, and as the questions roll in, I'll just quickly go over them.
Sounds good.
So these are some of our patient resources that I want to make sure all of you have access to. Transplantliving.org, the National Kidney Foundation, of course, they have tons of patient education, oftentimes free resources. The SRTR has transplant outcomes. Findakidney.org is a site that talks a lot about the microsite program, which we'll see in the next couple slides, and the American Transplant Foundation and the National Donor Assistance Center. So all websites that you should definitely visit and become familiar with. Transplant Mentors is another wonderful opportunity if you would like to connect with someone who is similar to you, going through a similar experience. We are happy to set that up. We have found patients really like this, and they also choose to become a mentor after they've gone through the process, which is really cool. So let us know if you would like to be plugged in with a mentor. And then the microsite program, again, this is something we want all of our patients to create. If you are a transplant recipient waiting for a kidney and you have a living donor, and obviously if you do not have a living donor, you should make a microsite. But I even encourage patients who have a living donor to make a microsite because, you never know if you may need a transplant in the future. This is an opportunity for you to set yourself up for success and just spread the word about living donation, kidney transplant. It's a really easy site to create. You have a lot of people who can support you, myself included. We have coaches. And then people who are interested in learning more about living donation can access education through the website. And they can also get set up with a donor mentor, which is huge because this is someone who's been through the process. And then they can learn also about the donor protections. So in the next couple slides, you'll see some sample sites. This is a patient site. You can see at the top of the screen, there's the blue tab, see if they're qualified to donate, help share my story on Facebook, Twitter, through email. Their name is big and bold at the top. And then they write a little bit about why they need a transplant. And the next slide shows why they need a kidney, how you can help, donor supports and protections, which is massive because people who become living donors maybe have to take some time off of their job and they may lose some wages. So there's lost wage protection. There's also protection and support regarding travel expenses. And God forbid they ever need a transplant in the future, there's some protections in place. So it's really important to know about all these things. This is called Donor Shield, and that's through the National Kidney Registry. I think we have another sample website. Yep, another wonderful patient of ours. And it also just teaches people how they can help you. Maybe they can't donate, but they can share your story and just increase the amount of people that see your website. And then the next slide really just covers our transplant volumes. As you can see, we've been quite busy. In 2023, we have had a remarkable year. We've done actually quite a few deceased donor transplants. We obviously still remain high volume for living donation, but we've been really busy, which is great. And we're shortening our waiting times for a deceased donor transplant. We're telling people on average about 3 years. And so that's because of the allocation change. And that's because there are new opportunities for patients to accept, expanded criteria donors and whatnot. So just wanted to show you guys our volumes and how busy we've been, which is amazing. And next slide, I believe we highlight our 60th years. In 2023, we had our 60th anniversary, and it's been an amazing, amazing road. Judith has been a part of this team for 27 years. And so she knows a lot about the history and the pictures on the left, and obviously the pictures on, it's technically the right. The pictures on the other side are from today, and it's just a beautiful montage and represents the hard work and history behind transplantation. And then again, our year in review, we had an incredible year in 2023, and I know we'll keep going in 2024. And please connect with us on social media if you haven't already. Our Instagram, Facebook, YouTube, and Twitter are up and running. And I try, as the manager of the social media accounts, to keep it updated with not only events, but new policy changes, new education, research, and just staying connected to the transplant community. There's often a lot of support groups, resources. There's patients supporting one another. So visit and follow and let us know what you think. And then our website, of course, which if you've not been to our website, please go. A lot of our webinar recordings are on our website and our YouTube channel. So go explore, check it out. Let us know what you think. And then this is our, the next slide will have our agenda, but this is our new webinar series, Virtual Insights on Kidney Transplantation. Obviously, you've all signed up today. We are still encouraging new patients, people from outside our center to join. Anyone's welcome. And again, as you know, we meet on the last Tuesday and Wednesday of the month at 11 o'clock. We repeat the same session on Wednesdays. And we're really excited. So the next slide has our upcoming agenda for the rest of the year. We've got post-transplant care next month. Then we have nutrition, which I know everyone will be excited for in August. September, we're going to cover mental health and the support element of transplant recipients. And then in October, we're going to actually do a topic on pediatric transplant. And then in November, we're going to do an overview. And then December, we'll probably take our little monthly hiatus and start back up again in January. So if there's more topics you'd like to see, any feedback, please submit. And again, she's going to kill me, but I want to highlight Judith and all of her efforts in making this all possible. Her dedication to patients is just hard to put into words. Judith has lived, breathed transplant, and she's the most passionate person I know. And so it's been great to work with her and do this webinar series and learn from her. So we've all been very lucky to have Judith to teach us, and just want to say thank you again.
Thank you. It's been my honor.
All right, guys.
Thank you so much for joining us. Thank you to our wonderful speakers. And of course, thank you to Judith for such an amazing career and all that she has done for so many of us.
Yeah.
Have a wonderful day, everyone.
Take care. Bye-bye, guys.
Bye, thank you.